At this point, it's my pleasure to lead you into our next plenary session entitled Centering the Health Worker, Digital Health and Health Workers, Balancing Patient and Health Worker Needs. We have a wonderful range of panelists. I'll introduce them more as they go into their sessions before their remarks, but let me start by briefly acknowledging Dr. Wuleta Lemma, Honorary Associate Professor, Director, Center for Global Digital Health and AI, Wollo University in Ethiopia. She's also the CEO for Lalibela Global USA Ethiopia. Dr. William Mapham, founder and CEO of Vula Mobile, South Africa. Dr. Wendy Leonard, Executive Director for TIP Global Health. Kira-Leigh Kuhnert, South Africa Program Manager for Stanford University's Digital Medic. And Dr. Charles Prober, Senior Associate Vice Provost for Health Education and Founding Executive Director of the Stanford Center for Health Education. At this point, I'd like to give a little bit of a summary of Dr. Wuleta Lemma. As we know, she's an Honorary Associate Professor in the College of Medicine and Health Sciences at Wollo University in Ethiopia. She's also a Clinical Associate Professor and Director of the Center for Global Health Equity, School of Public Health and Tropical Medicine at Tulane University in New Orleans, Louisiana. She's an expert in tropical medicine who's been working for the past 25 years, mostly on HIV and AIDS, malaria, MNCH, and infectious diseases. She's also the founder and CEO of Lalibela Global, a technology company that includes among its projects an African health passport system. Welcome to all the speakers and panelists, and welcome, Dr. Lemma. Over to you. Thank you.
Thank you. Can you hear me?
We can hear you very much.
Thank you very much for inviting me to speak to this very important topic, digital health and health workforce, and also the balance between patients and the health workforce. I wanted to start this from the patient perspective. Our patients have been working in digital health for many, many years. And I have noticed in Africa, the mobile revolution, where mobile is in the hands of merchants, nomads, agriculture experts, farmers, our mothers, everywhere. The mobile is there. And the mobile is also with our healthcare workers. And how do we make sure that the information, the digital information explosion that we see around the world also benefits both our health workers and our patients? WHO said that by 2030, Africa will need 4.8 million health workers. In 2013, we had 1.8 million health workers. So how do we do that? How do we empower? Where do we get the health workers? Number one. Number two, how do we reach our patients and have a balanced system between providing the services to the rural population and also to the urban population in Africa? So for me, there are three things that are very important. When we talk about empowering our health worker or empowering our patients in this digital revolution, I don't think we should talk more about technology. We should talk about the health system, the problem of the disease. In Africa, currently we have in some countries more than 23% problem with NCDs. We also have a lot of problems with malaria, HIV, and as we heard earlier. So what do we need to do? For me, it starts with making sure that our health workers coming from the schools, from our nursing school, from our community health schools, they need to be empowered with the tools they need, the digital health they need in their education, in pre-service education, so that when they go out, they are familiar with dealing with different devices, which the population has. Population is exploring. Africa is one of the fastest continents in getting mobile devices. So I believe we need to change our education system to make sure that in the education system that we should have education for our healthcare workers. Number two, I believe also we should make our digital innovations very friendly to our health workers, to our community health workers, to our doctors, to our patients. I've been working in digital health for many years, like I said. Many of our hospitals and clinics, from the health post to the big hospitals, the paper system is very cumbersome. You cannot find a patient information system, let alone from one hospital to another or one clinic to another. From within the hospital, our paper system is horrible. So how do we make sure that our paper system, people think whenever I go and talk to people on digitization paper, they tell me, oh, it is expensive. But paper is expensive. It's extremely expensive, but we don't think paper is expensive. So how do we make sure that our patients from the village to where the healthcare workers are taking care of them, like we heard some wonderful things today, for example, how do we make sure that our patient information is continual? It's not one-off. If I'm a patient, if I'm a malaria patient today, 6 months from now, if I break my leg, me, 2 years from now, if I have a baby, me, I don't need 3 vertical solutions. Me as a patient, I need 1 vertical solution that take care of me as a patient. And I believe this also will help our healthcare professionals. They are overworked. They don't have time to, when 100 patients or 50 patients or 30 patients are standing in front of you, you really don't have time to take care of them. So sometimes I feel our problem is for both the healthcare workers and the patients, we create solutions doesn't think of the patient. Me, I can have 5 diseases. I can go in 30 years or 15 years or 10 years, 20 times to the hospital or to the little clinic around me. So I think that's why I believe responsible design of technology. A technology that makes sure that talks to the healthcare worker and to the patient. I believe sometimes in our enthusiastic approach to bring solution, we forget the cultural aspect of a solution. What does a solution need? What does our healthcare need? A healthcare worker working in a rural area in Benin may be different in a rural area in Ethiopia. I cannot bring something, currently I'm in Europe. I cannot just bring it and say that it has to work in Benin or Ethiopia or Ghana or South Africa. So I always, in this work I have done, I'm a healthcare worker, I work with IT people, but I think what we are missing is the anthropologists. We need them. We need them to make sure the devices that we design, the solution that we design are appropriately looked at by our healthcare workers and by our patients. I think if we do that, Africa, the Africa we want, 2063, the Honorable Minister mentioned, we will get the Africa we want. I believe, I challenge healthcare workers who are listening to me, work to make sure to think of the patient. If we think of the patient, if we think of continual system, if we educate our healthcare worker from community health to the specialist on new technologies in Africa, you'll be surprised. Africa has one of the youngest population in the world. We have a lot of young people who need jobs. If we integrate them to create jobs for digital health, if we integrate culturally sensitive technologies, I really believe we'll have the Africa we want. I'm honored to be here. Thank you very much.
Thank you very much, Dr. Lemma, for your remarks. Definitely a lot of nuggets that are coming through, talking about the information explosion, looking at the root cause of the health system, friendly innovations that are responsible. So definitely things to think about. Our next speaker is Dr. William Mapham. He's an ophthalmology registrar at Tygerberg Hospital and the founder and chief executive officer of Vula Mobile, an award-winning referral app that links primary healthcare workers in remote areas with an on-call medical and surgical specialists in South African hospital. The medical app, which was initially only for ophthalmology referrals, quickly expanded into cardiology, orthopedics, allowing specialists to access under-serviced areas in a quicker and more efficient manner. Welcome, Dr. Mapham.
Thanks very much, and thanks for organizing the event. I really appreciate the previous speaker, Dr. Lemma, and I thought I'd show you some slides on perhaps how we are helping to talk about the problem as well. So as mentioned, Vula Mobile connects frontline healthcare workers with specialists. I've experienced, I'm from the Eastern Cape in South Africa, from a rural area. My passion is improving healthcare in rural areas. This is the road to my first job. It was an hour-and-a-half drive to get petrol and another 3 hours to get ice cream. We kind of define that as being rural. This is a referral letter. We talked about paper just now that I wrote myself in 2004. The patient had an eye condition. It looked serious. I didn't know what it was. So I wrote the letter and I said, please go to Umtata. It's our nearest eye clinic. It's only 3 hours away and hopefully they can help you. The next time I saw the patient was 7 years later when I went back to volunteer as a specialist. Unfortunately, he came to me with the same letter that I'd written all that time ago. He was so excited to see a specialist, but he'd gone blind in that eye because the treatment, he had required simple treatment. We had the treatment when we first saw the patient. I just didn't know as junior doctor. You know that many patients, both in South Africa and many other countries, travel huge distances to get to specialist care. However, the problem wasn't just in the rural areas or from the GPs or from the nurses. You can see here, I'm a specialist. I'm seeing patients, I'm teaching students, and the phone in the corner just rings off the hook with people like me in the past trying to get hold of a specialist. So we had to solve the problem both for the rural health worker and for the specialist. So that's why we invented Vula. It's a referral app linking GPs and primary healthcare workers with specialists. As mentioned, we started off in ophthalmology. It's now used in 53 different specialties. And like Dr. Lemma was saying, it's not, rather than having sort of different vertical apps, you've now got one app that works across multiple different specialties. And the way it works is that every specialty has a unique form. And so by the time the specialist gets the information, they can respond accordingly very, very quickly. There's a couple of numbers. I was hoping we'd turn 23 before this talk, but we only had 22,000, almost at 23. And almost 650,000 patients have benefited to date. It's currently running at about one patient every minute. What's very interesting, we talk about how do we decrease the number of healthcare workers that we need. On average, the specialist is able to guide the primary healthcare worker in 1 in 3 cases so that they manage the patient remotely when they first see the patient. And the average response time is from the specialists on Vula, because we publish the response times, is 15 minutes. So typically while the primary healthcare worker is with the patient, they get the advice that they need. What was interesting when we looked at obstetrics, it was actually in 51% of cases, the specialist could actually help the primary healthcare worker manage the patient remotely, and that patient didn't have to travel to a tertiary center. So this is fascinating because basically what this means is the midwives, the nurses, and the community healthcare workers had done exactly the right thing. They just needed to be reassured that they had done the right thing. We talked about training. Dr. Lemma talked about this as well. So Vula is now used as a training tool for clinical associates, nursing, physio, and for medical students. I just thought I'd show you a couple of quotes from different types of healthcare workers using Vula. This is from emergency medicine. Being able to contact the registrar or specialist on call saves time, anxiety, and frustration. We also offer the specialist department stats. So every month they get to see where all the services are needed and what they can do. And so the quote is that they can actually see where the need is and see what we can do to plug the holes in the system. And one of the questions we might be asked in the group is like, sure, what about the medical legal considerations? And this is one of the reasons people use Vula, because it does actually help them achieve medical legal compliance. So that's a very brief overview in less than 5 minutes. You're welcome to look at the website and also welcome to contact me directly and happy to answer any questions.
Thank you so much, Dr. Mapham, and just sharing Vula Mobile and also this technology. I think, there were so many synergies between what Dr. Lemma was saying and also now this actual tool that's being used and it extending, especially to those rural areas. And, it is important to get out to the furthest of the furthest person out there and also just being able to see what the user experiences are. Thank you. Our next speaker is Dr. Wendy Leonard. She founded TIP in 2008 as a means of inspiring local health system innovation to provide high quality healthcare to vulnerable people in resource limited settings. She served as the first physician to volunteer for the Clinton Foundation's HIV clinical mentoring program in Rwanda, and she's continued to work as an educator and consultant to the healthcare providers in rural Rwanda. In the United States, she's dedicated to providing quality healthcare to vulnerable members of her community. She's the director of Santa Cruz County's HIV Quality Management Program and has served as the county's tuberculosis controller since September of 2007. In this work, she has successfully collaborated with public health around HIV and TB care, including program design, management, and evaluation, and individual patient care. In prior years, Dr. Leonard served as president of the board of directors for the Santa Cruz AIDS Project, where she worked to expand HIV prevention, education, and care services to the Latino community. She, of course, has received a Bachelor of Arts degree in biology with a minor in healthcare, social issues from the University of California, San Diego, and she went on to earn her medical degree at Albany Medical College. She's been certified as an HIV specialist by the American Academy of HIV Medicine for over 10 years. Welcome, Dr. Leonard.
Thank you, Shombi, and I'm for that very long biography. It's such an honor to be with this amazing group of panelists. As you mentioned, I'm the executive director of TIP Global Health. I'm going to share some slides very briefly. And at TIP Global Health, we are really passionate about making sure that communities have what they need to provide and receive high quality, effective primary health care that really allows every community member to thrive. And I'm really excited to be listening to this all of the panelists, because I think we have such perspectives on what it takes to provide and receive care. So as everyone in this group already recognizes, driving effective primary care means really focusing on prevention of care conditions before they happen, early diagnosis, early treatment, and continuity of care. It's not really about a condition, it's how we manage patient care. To achieve this goal of primary health, it requires that a community member is accessing care, receiving high quality care that inspires her to go home and adopt care recommendations, sustain those care recommendations, and then access care again. And that's a lot of work for a community member, as Dr. Lemma has mentioned. So what drives this cycle of primary care? It's really the relationship between the community member and our frontline healthcare worker. But the reality is, this is what most frontline local health systems look like around the globe. We know that provider-patient relationships are the cornerstone for primary care, but poor local health system design and competing priorities are really straining this relationship beyond effectiveness, leaving both frontline health workers and the community members they're serving feeling disconnected, powerless, and exhausted. So at TIP Global Health, this is what we're really keenly focused on trying to solve. And so we created a digital platform called eHeza that was designed to build relationships to improve health outcomes. eHeza is designed to ease workloads by working within existing workflows, and it incentivizes accurate data collection by utilizing the collected data at the point of care to inform care in that moment. We utilize data trends to inspire healthy behavior change and maternal engagement in care. It recognizes the realities on the ground, and it works in settings of unreliable internet. And our implementation strategies really prioritize integration with the existing constraints, existing culture, and context within where we're implementing. This is a quick example of how we utilize data to inspire and inform. It's at an individual or a population level. This is a progress report that's very difficult to see, but it's an antenatal care progress report for a pregnant woman. And it outlines all of the conditions, medical conditions within her pregnancy, but it also highlights milestones that were meaningful to her. So on a timeline, it celebrates when the fetal heart tones are heard for the first time, or when fetal movement happens for the first time. And then we also trend things like fundal height and BMI, so that mom feels really engaged in her care and in the progress of her pregnancy. Similarly, we have dashboards at a population level for nutrition, many different conditions, but in this case, this is acute illness, where we're really looking at what are the trends, what are the numbers of COVID-19 suspects, malaria cases. We also look at things like fever by cause. And so we can see trends in fever of unknown origin or fever as related to malaria, so that we can start to see trends emerging in communities. EHESA is designed to strengthen communities of care. So it is, whether you're a community health worker in a village or a nurse or a clinician at a health facility, you sign in based on your user type. And then based on your user type, it allows for various functions that are specific to you. All of the data that you enter into the system populates a shared report, as Dr. Lemma has commented on. It creates one shared record. So wherever that a community member goes, her information is available at every level of care. It also has diagnosis and decision support at each level that is tailored for the needs of those levels of care, case management as well as data privacy based on user type. The ease of use of EHESA is really reflected in our proficiency scores, which are an average of 95%. That also reflects our training process. And we've been able to demonstrate an improvement in the quality of care of 120% from baseline, 6 months post-implementation. We've seen dramatic improvements in efficiency and also health outcomes as a result of engaged patients and improved quality. We have over 60,000 mothers and children on the system now, and we've conducted over 200 unique visits. And just for the sake of time, I'll move quickly. This is an image that I love to end with because it's a community-based nutrition program in the village in rural Rwanda. And you can see a grandfather leaning in with his community health worker, looking at the growth trends of his grandchild, and the whole community is engaged and involved in this. And this is what we see as the future of healthcare and the use of digital tools to facilitate effective primary healthcare delivery.
Thank you so much, Dr. Leonard. Just really great there. Immediately when you said technology that inspires and informs, I think that's exactly what we're going for today and in the work that we do every single day, especially as we going back to Dr. Lemma's word, explosion of digital technology and how we're integrating it into healthcare. At this point, I'd like to introduce Kira-Leigh Kuhnert, who's a digital medic program manager in South Africa. Kira-Leigh leads the country team in the effective development and implementation of digital medic. Through her experience, Kira-Leigh brings a national, regional, and global perspective to digital medic. She is strongly committed to facilitating positive social impact and addressing the challenges of inequality in Southern Africa. Kira-Leigh is passionate about human rights, in particular women's rights and rights of marginalized groups. In addition to these interests, Kira-Leigh is a systems-oriented thinker. Kira-Leigh has a master's in international relations from the University of Cape Town. She also has a Bachelor of Social Science in Gender and Women's Studies, also from the University of Cape Town, and an honors in development studies from the University of Cape Town. Welcome, Kira-Leigh. Thank you.
Thank you. I'm just going to also share some slides just to get us going. Very good. Great. So thank you. Digital medic comes into this discussion really around the provision of health education to equip and empower healthcare workers, particularly those located in the community. So I look forward to sharing and introducing you to Digital Medic and how we develop, create, and evaluate health education with and for the learner. In most cases, this is with community health workers in low and middle income countries. We have understood the potential of digital health tools in healthcare and education, and see the opportunity that it brings, which has become even more apparent over the last 18 months. So we hope to build on this moment. Our mission is to create engaging, high needs digital health education identified with partners that can scale quickly and cost effectively. By developing relevant health education, we are equipping health workers to better serve their communities and ultimately having a positive impact on health outcomes and access to healthcare. Essential to our approach and production process is human-centered design, really to ensure that the health education is relevant, accessible, and resonates with the learner. This often involves focus group discussions with community health workers and understanding how much time they have in their days to be able to access a short course or information on a particular area, what those high need areas are, and how we can work with them in building out and emphasizing the elements that they're needing information on, both for themselves and for their beneficiaries or clients. We believe that our approach is accessible, engaging, adaptable, scalable, and credible. It addresses the particular challenges that have been identified through engagements with collaborating partners on health within the health education environment, as well as through our learner evaluations and their reflections on how they have accessed the material and kind of what the gaps are. Our visual-centric content really aims at overcoming varying literacy levels of the learner, and the use of storytelling is also effective. We've learned that this is really key in having those learning outcomes stick. So you can remember a story oftentimes better than a slide like this. We understand that there's not equitable access to devices and data. So we've really tried to develop and design our content for use across a variety of devices and the spectrum of data access. This allows healthcare workers to access the information that they need, when they need it, and where they're at. For us, over the last 18 months, we've really looked at the SMS IVR messages as a key way to get information to community health workers in areas where they only necessarily have a feature phone. But as you can see on the spectrum, it goes right from kind of a smartphone app-based education through to web-optimized learning experiences, be it through Coursera or other platforms. In addition to developing health education with our learners, we really conduct rigorous impact evaluations. This is to measure health outcomes once our content has been accessed and to understand from the learner what that experience was like and how then we can better that experience and really address their needs. The following two case studies provide examples of how our content finds the balance between education needs as expressed by the health workers, as well as the patient's queries and their information needs. Okay. In the Western Cape province of South Africa, over 18 months between 2019 and 2020, we did a randomized control trial with mental mothers from the Plenary Maternal Child Health Nutrition Center. We were able to test the impact of health education, both with the mental mothers, their community health workers, and their beneficiaries on exclusive breastfeeding. The community health workers in the control group were provided with standard face-to-face perinatal in-home counseling with their beneficiaries, and in the treatment group provided the same face-to-face counseling, but also included the Digital Medic breastfeeding education videos. After that, our randomized control trial, we found that there was a significant improvement in breastfeeding, in the exclusive breastfeeding across the mothers in the treatment group. And through our in-depth interviews with the mental mothers, it really highlighted the added benefits and increased efficiency of having these digital educational tools and materials for when they are in the homes with their beneficiaries and with the mothers. Many community health workers really shared how having this content allowed them to actually catch up and ease up some time for that capturing of admin that is required, which is quite a heavy kind of caseload, usually when they're meeting with beneficiaries, and also provide their space to open up some conversations with mothers and caregivers by using this tool and the educational video that they are viewing as that entry point. A second product that kind of learning course that we have created with community health workers is this advocacy training course. This was created with community health workers as the experts. So again, kind of quite extensive focus groups with a number of members from the Community Health Impact Coalition as providing the community health workers as that group. And then really just identifying identifying their needs within advocacy and developing this free training, digital training course so that they can become effective champions for change within their community. There are now 110 community health worker learners enrolled. This was only recently launched in June of this year, and it is available via various the Digital Medic app platform that you can download for free, and then be able to access content online and offline, so that when you are in a Wi-Fi enabled area or have access to internet, you can get that learning material and then download it onto your device so that you are able to access that when you are either in the field or in areas where you do not have connectivity. We know that community health workers are the ones that know their communities best and their health challenges and needs, and that they are that critical link for achieving accessible healthcare for all. So equipping them with relevant health information will go a long way in achieving the universal health goals that we have set out. And these are just some places that you can kind of find out more information about Digital Medic. Follow us on various social media platforms just to keep up to date with any new content that we're going to be releasing, which we do on a regular basis. Okay, Charles, I'm going to hand over to you if you have any input.
Great, thank you so much. Before we hand over to Charles, maybe just to do a quick introduction of him. He's the founding executive director of the Stanford Center for Health Education and senior associate vice provost for health education at Stanford University. He's a professor of pediatrics, microbiology, and immunology. He's an expert in pediatric infectious diseases with an academic career focus on epidemiology, pathophysiology, prevention, treatment of infections in children. Dr. Proba has been involved in medical education throughout his career. He's directed a number of undergraduate and graduate student courses in the classroom and also at the bedside. He has served as Associate Chair for Education for the Department of Pediatrics and Senior Associate Dean for Medical Education at the School of Medicine between 2007 and 2017. He has lectured locally, nationally, and international on infectious diseases and medical education. Over to you, Dr. Proba.
Shombi, thank you so much for that introduction, which I think may be longer than my comments. Really what I wanted to say at this meeting is, as Shombi just described, I've been very much involved in health education for a long time, but I only had the privilege of understanding the great unmet need for health education a few years ago while I was Senior Dean for Education at the School of Medicine, when I learned more about community health workers through conversations with some of my friends and colleagues at Stanford who had been much more involved in global health. My involvement with healthcare and teaching medical students and residents and fellows was really very focused on North America and very focused on the walls of Stanford, that some of which are sitting behind me. And my mind had not been opened to the extraordinary work that community health workers were conducting around the world. This collided, at least in my mind, with the opportunities that were being presented in the digital world and being able to share some of the tools that the other panelists have commented upon with those in the greatest need. And I saw this first play out in North America. I was a colleague of the founders of Coursera and saw them take their lessons that they were offering to 200 or 300 Stanford medical students and stand those courses up to 50 to 100,000 people around the world. And it became so obvious, and it's of course obvious to everybody here, what the potential for sharing health information is. So when we established Digital Medic, which stands for the Digital Medical International Collaboration, it was with the intent of trying to do, again, what the panel members have already spoken about, deliver that healthcare information to those who had the biggest lift in the world, the lift of providing some degree of equity in healthcare information to their clients around the world. And my first really direct and inspirational moment around this is when I traveled to South Africa just after we had set up our office there, where Kira hangs out in Cape Town, and had the honor of going to Palani's in one of the communities around in Cape Town, and talking to the community health workers about the tools that we were working on so that they could, with their tablet, take the information to their clients. And what I heard instantly back from them was, first of all, appreciation, which is not what we were seeking, but rather but was there. And them saying that when they show these digital assets, brief digital assets, to their clients, it makes their job more fun, more interesting, and in their opinion, more effective. And their clients were, they believed, better educated with this information and more inspired to follow some of the healthcare guidance. And it just struck me, and that this is so parallel to what I see, again, within these walls at Stanford, where our medical students, who are a very different type of person, obviously, with different assets than these community health workers, they prefer to see their assets and learn about medicine and delivery of healthcare through digital content. In fact, it's so much an issue that we've almost given up on lectures, because who wants to listen to a long lecture? So when I listened to the other panelists talking about the app that allows the consultations with distant physicians and the digital advantage of that, it just resonates so much about the opportunity that sits in front of us to reach those millions of community health workers around the world. And to hear that there's a need for almost 5 million community health workers in Africa to be trained in the next few years, the solution is in our hand. And our challenge and our opportunity is to take that solution and distribute it, and this is obvious, as broadly as possible. And as somebody said in the previous session, to keep the community health worker at the center of our attention for all the incredible work that they do, and empower them to expand that work on behalf of all of their clients, all of the persons that live in rural areas far and wide. And the last thing I'll say is my enthusiasm for this, thankfully, is shared by those who have the assets to be able to help us do this, certainly including the supporters that are on this call and those that donate to our different needs. And also in Silicon Valley, I've had conversations at quite high levels with some of the leaders in the Valley, those at Apple, those at Google, and others, who are asking themselves how they can now begin to share information that may actually and will save lives as their social responsibility to our ever-connected world. And when I hear that from them, I know that they've got the assets to be able to do it. And if they have the passion to do it, it will be done. And so I want to say how honored I am to be on this panel, how honored I am to have met community health workers and work with them, and how just incredibly inspiring they are in terms of the jobs that they do. Shombi, thank you very much.
Thank you so much, Dr. Proba. Thank you so much, Kira-Leigh, Kuhnert. I think so many salient points coming through. How are we taking these digital tools to scale quickly, human-centered design, leveraging programs between the different organizations, and also it's really in our hands. We have the opportunity to change the landscape. We do have a couple of questions that have come through on the Q&A for everybody, or somebody that's joined a little bit late. Feel free to drop in your questions there. I see Dr. Mapham has already answered a question here that was coming in from Gareth. Feel free to drop in those questions in the Q&A. I have a couple of questions for you before we sign out of this session. Maybe to Dr. Lemma. and maybe to Dr. Mapham. Looking at the landscape of digital health tools today, where do you feel health workers are best being served? And conversely, where are we letting them down? Maybe Dr. Lemma first.
Thank you very much. I think where they are served, I should answer from the positive first. I think there are a number of tools, like we saw, being used by community health workers all over Africa and in many of the 54 countries. And they are saving lives. They are helping our healthcare workers. But I think where we are letting them down is more than 80% of all the mobile apps or technologies in Africa are donor-based. There is no public-private partnership. Professor Charles spoke about Google and Amazon and others who are looking at Africa now. They are setting up different things in Africa. I really think to honor those community workers, some of the apps which are, quote unquote, paid by somebody else need to be sustainable. There has to be a program or system so that I'm a community worker. I use an app that was developed. I use it for 3 years. And when that program collapses or when there is no funding, done. So I think we need to think when we actually, it's great. It's the donor-driven apps all over Africa. But we need to think before they collapse, how we can make them sustainable. So that the community worker we are helping today, we can help them 10 years from now. That's my message. Thank you very much.
Thank you, Dr. Lemma. Dr. Mapham?
Yeah, I'll actually kind of talk about that a bit more because we talked about so many apps being released, and there's nothing bad about that because every little local area is going to need their local solution. So I think as we do design things, even if you solve a solution for a rural village and it really works well there, that's good. Like, it doesn't matter, it's not necessarily being used everywhere across the world. I totally agree with Dr. Lemma in terms of the donor-funded projects. We call this death by pilotitis, where as soon as the pilot funding ends, that's the end of everything, And to be honest, it took us a long time to find a business model that worked, that made us sustainable. We were going from 2014 to 2018 before we discovered a way of actually making ourselves sustainable. So it is a big problem and a big challenge. But I think there's a growing awareness now, because we actually registered as a private company, that you can actually raise capital, you can raise funding, you can find business models that are perhaps more flexible in the private sector than just donor-funded NGOs. So perhaps that's one option. And I think in terms of letting health workers down, it's not true with the cases here, but there are some cases where you actually put admin on top of the person's workload. So not only are they expected to do their work, but they're also expected to collect information for information collecting's sake, because the donor wanted the particular things recorded. So I think that is a challenge, that you have to make life easier for people, not more difficult. So the data collection happens because they're doing their job and doesn't stop them doing their job.
Great, and you've just went into the next question I was going to ask. So maybe Dr. Leonard and Kira-Leigh, how can we make sort of reduce the burden on the workloads so that as we design these tools, they meaningfully work for the health workers? Maybe Dr. Leonard?
I'd love to talk about that. I'm so passionate about that particular topic. I'm a frontline healthcare worker here in the United States as well, and I've been using electronic medical records here for as long as they've been here, about 10, 15 years. And in the US, what we've seen is dramatic increases in burnout as a result of directly related to electronic medical records. And it's because it was poor, they were not designed for frontline health workers. And so at their foundation, they were designed, in our case, for billing, and then repurposed for direct patient care. So my biggest passion in all of this is to not export bad ideas. And I see that, unfortunately, a lot. So how do we learn from the lessons of places like the United States and do it different? And I think one of the biggest challenges, and to Dr. Lemma's point around donor funding, which we're really grateful for, but who drives the design and development. So we tend to have funding that goes to governments to serve their needs, which is very relevant, and they need data, but the users are in the conversation. And so that's where I think a lot of the challenges come. How do we make sure that the users of the digital tools we're creating have a voice? Because the data is the same, but we can collect it in a way that is utilized at the point of care and incentivized and decreases workloads, but we need to have them in the conversation.
Great, thank you. And Kira-Leigh?
And to add on that, from a digital medic point of view, the aspect that I can talk from is that really to engage with the learner, to understand their needs, how they're going to access that information, how does it make sense for them to get information that they can fit into their day. So, but even to get that information and to be able to engage with community health workers, you need to do it in a way that's not also burdensome. So to add on extra meetings, or let's meet at various times, so to really find out where in a workday you are able to meet. So whether that's being being built into an existing meeting that happens with their supervisors, or kind of as a collective that they get together and share case studies. So to try not to be burdensome on their time either. So really just meeting the learner where they're at, understanding their needs, and co-developing, co-designing the content and the course, so that it can be utilized. Otherwise, you often have information that is created and is not accessed. There's some fantastic information that is available, and if it's not going to be in a short kind of snippet, like 3 minutes, 5 minutes max, our attention spans are all kind of quite pulled in various directions. So making sure that you're able to get that information across in a specific period of time that is relevant and sticks. So understanding all those variables.
Great, thank you. And maybe Dr. Proba, just in closing the questions, there's also a last question from the Q&A section. I think it's going to Dr. Mapham. What data protection laws, or at least now that we see that there's a rise of data protection laws globally, how best can we design for privacy?
So I think you have to take this very seriously. It's not an option to do this. It's a complete must-have. Even as a small company ourselves, we have a full-time compliance officer to make lives easier for anyone following. She's published. I'll put a link into the Q&A on how to make your apps or your systems medically compliant. So, for example, we've taken the hardest ones. So we HIPAA certified for the USA. We undergo an annual GDPR audit, which is the European one. And between two of those, it does cover most African environments, but every country has their unique medical legal requirements. So for instance, South Africa, it's called papaya. And so you've got to meet those requirements as well. So yeah, happy to share our compliance officer's time with anyone who's keen on that, but it's an absolute must-have. It's very technical. It's not something like you can just say, oh, I'm compliant. It's a lot of process that you go into. For example, even the company ourselves, we have to be compliant so that we can offer compliance services. So yeah, it's technical, but it's perfectly doable.
Thank you. Dr. Proba?
Yes, I just a couple things. One is I'd like to underscore the point that Kira made, and I'm sure is quite evident to all of us, that the educational content that we try to share with the learners will only be valuable if it resonates with the learners. So the idea of having focus groups and developing the content in collaboration, which is again the C in digital medic, in collaboration with and contextualize in the correct environments, is such an important piece of the problem. And we have a team that does that. And then the other end of that, the other side of that, is after the content has been delivered, to try to determine if the intended effects have been achieved. The intended effects being obviously boosting knowledge, changing behavior and attitudes, and ultimately changing practices that yield increased health. So the evaluation process is a very important part. As I think all of us know, there are very few people who seem to be interested at the donor side of funding evaluation. It's kind of a paradox because they don't necessarily want to support you unless you can show them that you know what you're doing. Fair enough. But you can only determine and show that you know what you're doing by evaluating it, and you need funds to evaluate it. So trying to figure out how to sustain that important cycle of feedback from the learner is critical, and building a business model has been, as has been alluded to by other panel members, becomes very important. What we have chosen to do at Stanford is we have a number of courses domestically that are tuition based and generate revenue in another part of our center, and we can then bleed that revenue over into the digital medical side and do some of the things that we need to do to convince grantees and donors that we know what we're doing. So it's moving funds from one revenue generating part to another, which is a non-revenue generating part. And just to be clear, what I mentioned about the Apples and the Googles is not them distributing their apps, because I agree with all the comments made that the apps come, the apps go, and then what do you do when they're gone? But rather they are, as far as I can tell, sincerely interested in trying to help develop a global solution to an education distribution problem. Just yesterday, I spoke to the head of YouTube Health, who we're working very closely with, and he actually raised the question. Made me think he didn't listen to our prior conversations. You know, we at YouTube want to figure out how we can generate content that can serve the world's population of community health workers. Do you think that's a good idea? And of course, I was quite happy to express my thinking about that. So I think that they can help us develop a solution. I don't know what that solution is going to be, but they realize social good should be part of their business model. Thank you very much, Shombi.
Thank you very much, Dr. Proba. Because of time, we would have loved to have sort of a closing, but I'm going to sort of ask you to be a little bit creative here and ask the last question, and maybe ask Dr. Mapham to answer the question in the Q&A online. What are the hopes and dreams for digital health tools in the next 5 years? In one word, and then we'll wrap up the session. I know that's pushing you a little bit. Your hopes and dreams for digital health tools in the next 5 years. Yeah, go ahead.
I would say magic.
Magic.
Because when you do connect health workers with information and people, then magic happens.
Awesome. Dr. Leonard?
I would say thriving.
Thriving. Great. Dr. Lemma?
Empowered patients.
Empowered patients. You put in another word there, but we'll allow it. Kira-Leigh Kuhnert.
I was going to say penetration, so making sure everyone has connection, but magic I like.
I like the magic. A lot of great words there. Dr. Proba.
Access.
Access. Great. Wonderful. We've heard so many wonderful insights, and thank you so much for joining us on this panel today. I believe the audience are just enthralled with a lot of the lessons and what we can take from practical examples and how it's working on the ground. So thank you so much to you for joining me as panelists on this session. Really appreciate it. Thank you.
Thank you. Thank you.